Graves' disease was first put together or written about by Robert Graves, who was an Irish physician. That's a photograph I found of him, or a picture from the internet. Hopefully it's accurate, who really knows, but there was at least 6 or 7 resemblances of that, so I picked this one. And Dr. Graves found a series of 4 women who had a combination of enlarged thyroid gland, elevated heart rate, and eye changes. And it came clear to him that although he had no clue as to what may be going on here, that somehow these 3 very disparate symptoms could be tied together to one condition or a syndrome. And so, although again he really didn't know what he was describing, he found these 3 manifestations, and his initial speculation was that Graves' disease, or this condition, was primarily a thyroid problem. Primarily a heart problem, a cardiac problem, because the heart symptoms, the rapid heart rate and the very, very strong heartbeat were the primary and most disturbing symptoms to his patients. And so this is a photograph of a patient who has Graves' disease, and on the top left you can easily see the enlargement of the thyroid gland. The thyroid gland in Graves' disease is diffusely or uniformly enlarged. Rather than having a lumpy, bumpy consistency, it is generally enlarged and swollen. Sometimes the swelling can cause pressure and compression with regard to swallowing. Oftentimes that does not happen, but certainly the thyroid gland is enlarged in almost every case of Graves' disease. The visual symptoms that Dr. Douglas will talk about in more detail, of course, is one of the more important symptoms and signs to the patient because of the cosmetic issues and the psychological effects that it has. And this will be discussed more and more as today's presentations move on. There are certain skin manifestations. This is the person's lower extremity, and this is called Pretibial Myxedema. And essentially the skin in the lower extremity becomes very firm and rubbery and has the consistency of an orange peel, sort of that rubbery, firm consistency to the lower extremities, and that's Pretibial Myxedema. And here the fingers have a characteristic of what we call clubbing, where the tips of the fingers are swollen and enlarged, and this is another uncommon but certainly manifestation of Graves' disease. So Robert Graves put this together as a syndrome, and initially again he thought that this was primarily a cardiovascular disease, and now we know that it is actually not a primary cardiovascular disease, but it is actually an immunological disease. It's an immune system disorder. This is a very busy slide, and I don't even understand all of it, but the bottom line is that immune cells, B cells and T cells that are illustrated up here, are the primary culprits that are driving an immunological problem, an immunological chain of events that lead to overactivity of the thyroid gland. And because some of the antigens or some of the molecules or the molecular structures of the thyroid gland is shared with other tissues of the body, such as the fat and the muscles and behind the eye and under the skin, that the same immunological reaction can affect those other body parts. So it's sort of like a parallel universe where you have an underlying immunological problem that is setting off a bunch of other manifestations in the body, whether it would be the eyes or the skin. And of course, this is an incredibly complex scenario that is being unraveled more and more as time goes by. And as the understanding of these immunological processes improve, then perhaps more and more treatments can become available. just so that you know, there is really no treatment to treat the underlying immunological problem in Graves' disease. All the treatments that we have, whether it's for the thyroid or for the eye problem, actually there are currently no FDA-approved treatments for the eye problem. Soon there will be, but all of the treatments that we have are sort of band-aids that, for example, treat the thyroid overactivity or help with symptoms of the eye disease and allow time and hopefully reduction in stress and other things to help the patient along. So we're still very, very early in the understanding of the main pathological problems. Now, a couple of things about Graves' disease, as you see here, that it is the most common cause of hyperthyroidism. It is not the only cause. Many other conditions can cause an overactive thyroid gland, but Graves is the most common. Other possibilities would be a condition called thyroiditis, where a virus can cause overactivity of the thyroid. Nodules or growths in the thyroid can lead to overactivity. The difference between those other causes of hyperthyroidism is that they do not have the extra thyroid manifestations, the manifestations that go above and beyond the thyroid gland. So the eye findings and the skin findings are specific and a defining feature of Graves' hyperthyroidism. The peak ages where this develops is the 3rd to 5th decade of life. So we do have a lot of patients who are younger with this condition, and although anybody can get this at any age, it is generally between those years of life. It is much more common in women, 6-fold more common in women. Most thyroid disorders that have an autoimmune etiology are much more common in women. And that's the incidence, 20 to 50 new cases per 100,000 people per year. So I think it's 1 in 300 million to win the lottery. You definitely have more odds of getting this disease than winning the lottery. It's relatively common, I would say. It's not known. As I showed you in that diagram, there's a whole list of potential mechanisms that are going on. Obviously, the central difference between men and women is the hormone estrogen and testosterone, and so perhaps that hormonal difference can be a factor. We're not sure. I think the best answer to that question is that it's unknown, but perhaps there is a role for estrogen as a cause. We sometimes see a higher rate of presentation of Graves' disease, for example, in women right after pregnancy or at menopause, and so there could be something related to hormonal shifts that, again, with regard to estrogen and sex hormones, that could be playing a role here. But it's not really known. The same holds for hypothyroidism, which is the other side of the spectrum, the underactive form, and that form is much more prevalent in women as well. So there's something with regard to thyroid autoimmunity and female gender that seems to be a factor. Equally unclear are the other factors that seem to be correlated with the development of Graves' disease. So the current model for the development of Graves' disease is a sort of a two-hit model, that you need both of these factors, genetic and environmental, to sort of come together, and it's that intersection of these two sort of risk factors that lead to the development of Graves' disease. The genetics are not well understood, and you're going to hear that a lot today, that we don't know exactly what gene is driving Graves' disease, but certainly there is a familial predisposition, so autoimmune thyroid disease does tend to run in families. And then environmental factors that have been thought about include the intake of iodine from the diet, exposure to tobacco, infections, One infection is Epstein-Barr virus infection, which seems to be one of those infections that unmasks this genetic predisposition, and stress. I think in every patient that I see who comes to me with a diagnosis of Graves' disease, when I ask them whether there has been some form of an emotional stressor within the 6 to 12 months prior to the diagnosis, usually there is some factor there, something that they've gone through emotionally, and perhaps it's because of the strain on their immune system that stress can we know that at least tobacco exposure and tobacco smoking is something that could be modified. I mean, we can't change our gender, we can't change our genetics. Well, we can change gender, but the hormonal effects are still going to be pre-programmed. So tobacco exposure is really important because it not only is a risk factor for developing the condition, but in people who continue to smoke, the response to the treatment, both for the thyroid and the eye condition, is really, really set back. So that's one modifiable risk factor that can be addressed. So signs and symptoms of Graves' disease, essentially, it can affect any part of the body. Patients often ask me, well, I have this symptom, is this related to hyperthyroidism or Graves' disease? And I've learned to say that yes, it's possible. Essentially, it affects the entire body because thyroid hormone receptors are ubiquitous, they're everywhere in our body. Most of the patients end up losing weight, although 10% don't get that fringe benefit of weight loss, and they actually gain weight, and that's probably because although their metabolism is sped up, their appetite is sped up even more, and so there's more food consumption in relationship to weight loss from an overactive metabolism. Palpitations is very common, and in individuals who are older, it could be more than just the discomfort of a palpitation. It could convert into a condition called atrial fibrillation, and that's a condition where the heart becomes fast and irregular, and it's more than just an inconvenience or feeling this discomfort. Atrial fibrillation can be a risk factor for stroke if it's not treated. Shortness of breath, tremor, fatigue. People are often surprised that fatigue is listed as a symptom of hyperthyroidism. Well, I think that's because as anybody has ever taken a lot of coffee, if you have a lot of caffeine, that doesn't necessarily mean that you're going to feel completely energized. Ultimately, it's not going to be good energy, and it's actually going to be left being felt depleted when the thyroid and the metabolism is fast and in unregulated and unrestrained fashion. Heat intolerance, increased bowel movements. Mood is affected quite a bit. I think any sort of mood disorder can happen from just anxiety to depression to mania. And it's really amazing how these psychological symptoms melt away as the thyroid levels are controlled. And it is for this reason that thyroid function testing is hopefully, it's done by most psychiatrists, which is good that it's standard of care for psychiatrists who see a patient who has depression or anxiety, that they always include in their initial assessment thyroid testing, as this could be a very reversible and treatable cause of mood problems. Pruritus means itchy skin, increased thirst and urination, menstrual irregularities. Usually menstrual cycles become very light and sometimes completely absent. Sexual problems, men can develop breast enlargement initially, although it's not common, loss of sex drive, and hair loss. So there is really no part of the body that's not affected by hyperthyroidism. So when somebody comes to the office with those symptoms, they don't have to have all of them, but the most common one would be the weight changes, the heart rate being elevated, and the tremors. Those three, I would say, are the top three that tend to occur in most of the patients. These are the tests that we would run on them. These are blood tests, the TSH, T4, and T3, and we can then also check antibodies, those are the signals that are made by the immune system that we feel are driving this autoimmune problem. So this is a diagram of a person. This is the thyroid gland over here, and the thyroid gland makes two hormones, which we abbreviate as T3 and T4. The 3 and 4 refer to the iodine molecules in the hormone, and the thyroid gland in turn is regulated by the pituitary gland, which sits at the base of the brain and makes a signal called TSH, or thyroid stimulating hormone. So in a person who has Graves' disease, these TSH receptor antibodies are produced by the immune system, and they come along here, they bind to the receptor on the thyroid gland, and in a deregulated and unrestrained fashion, tell the thyroid gland to make more thyroid hormone. So what we see is that the thyroid hormone levels T3 and T4 rise, and through a process of feedback, pituitary signal becomes dampened or suppressed. So the common laboratory findings in somebody who has hyperthyroidism would be that their thyroid levels, T3 and T4, are elevated, and the TSH level is suppressed. And oftentimes the TSH is the earliest finding in a person who's progressing towards hyperthyroidism, that it's the most sensitive indicator of an overactive thyroid gland, even though that the TSH is not made by the thyroid gland, it's made by the pituitary gland. So TSH and thyroid hormone are part of this feedback loop. Any questions about these? So your doctor will be measuring these and all these letters, but the bottom line is that these are thyroid tests, and we're also looking at the TSH, which is the pituitary reaction to it. And think about this like a thermostat in your home. If the temperature in the home rises, the thermostat tells the air conditioning to go on. And if the temperature drops and the house is cold, then the thermostat swings the other direction and turns on the heat. So TSH will always go in the opposite direction compared to the thyroid hormones. So the first, that's a very good question. The first abnormality that happens as somebody is progressing towards hyperthyroidism is that the TSH goes down. And then as time goes by, the thyroid hormone levels go up. It is important to check both the T4 and T3 in Graves' disease because there are situations where the thyroid gland primarily makes T3 in an overactive state. And that's called isolated T3 hyperthyroidism or thyrotoxicosis. So the TSH is the most sensitive marker, but all the other tests need to be done to gauge the severity of the disease and also to determine the response to the treatment. So I don't know if I answered your question. You're going to ask me again. So we do like to measure all of them. But just measuring TSH by itself, even though that is the most sensitive marker, is not enough. Because it's oftentimes in Graves' disease, it's undetectable. It's zero. There's a less than sign, and then a couple of zeros, and then a 1. And so this is an undetectable number, and it just tells us that the person is hyperthyroid. And the thyroid concentrations tell us the severity and the degree of hyperthyroidism.
T4 and TSH?
I do. We monitor all of them in somebody who's on treatment. The reason being is that when we start a person on any form of treatment, the thyroid hormone levels begin to improve, and the TSH lags behind. So because the TSH is the most sensitive marker, it is the first thing to become abnormal and the last thing to become normal after treatment. So we do need to look at the T3 and T4 to make sure that we're not over-treating that patient because the TSH will just take a long time to come back. No, I agree with you 100%. It should be, there's no question that if a person comes with a symptom, you should check thyroid. The potential symptom. Now, I think you're going one step further, and I agree, is that should it be part of screening in general, that a person who goes in for an annual checkup who doesn't really have a particular symptom, should you still screen thyroid in that individual just to get a baseline or just to be thorough? And I 100% agree that it should be done. It's not currently part of guidelines to measure it. One thing that we didn't talk about is the effect of Graves' disease and hyperthyroidism on fetal development and pregnancy. And even in that situation, which is an incredibly delicate scenario where you have not just the mom's health but a fetus, even in that scenario, there's no universal recommendation in this country for monitoring or checking thyroid. So, and you know, how much a TSH test costs if you're just going to pay for it? About $20 or $30. It's not a really expensive test. So, you know, I'm not sure. You should advocate for it yourself. The hope is that if there's a symptom, even no matter how potentially unlikely it is to be a thyroid manifestation, you should still check thyroid function. So the TSH receptor antibody, which is the autoimmune marker that is felt to be driving Graves' disease, is a marker for Graves' disease, but the level of the antibody or how high it is does not necessarily correlate with whether somebody's going to get the eye manifestation, or if they're going to get the eye manifestation, whether it's going to be a serious one or sort of a nuisance and an inconvenience. So we don't have a laboratory correlate to gauge or predict even whether somebody's going to get the eye manifestations. That's a really good question. In fact, there are situations in Graves' disease where this antibody, which is felt to be the sort of underlying driving force, is not even detected in the blood. And therefore we rely on another test, which is the uptake scan, which I'll show you here. And that in a person who comes in with an overactive thyroid and the TSH is low and the thyroid levels are high, and we measure the antibody and it's negative or it's not detectable, that person still can have Graves' disease. And so how do we determine that? Well, then we have to do what's called an uptake scan.